The views and opinions expressed on this program do not necessarily reflect or represent the views and opinions of 580 WCHS or West Virginia Radio Corporation.
And good Thursday morning to you. It's 8:21 on 580 WCHS, the voice of Charleston, and this is Ask the Expert. I'm Jeff Jenkins with you this morning with our friends from WVU Physicians of Charleston. And they're here in the studio today, and you can give us a call, 304-345-5858, 304-345-5858. Looking forward to speaking with our guest today. We've been getting to know each other off the air a little bit. Found out we're both pioneers, but both from different schools, but we're both pioneers. Dr. Seth Adkins is with us. Dr. Adkins, how you doing this morning?
Doing great. How about yourself?
I'm doing well. Good to see you this morning, and we're going to talk about a couple of things this morning, including trauma and also robotic surgery and some things that are happening with that with WVU Physicians of Charleston. And again, the lines are open here on Ask the Expert, 304-345-5850 if you have any questions, 304-345-5858. Well, first of all, Dr. Adkins, just kind of introduce yourself and tell us your background and those type of things.
Okay. Well, my name is...
Move that a little closer to you there.
My name is Seth Adkins. I am a general surgery, trauma, and critical care physician with WVU Physicians Group of Charleston, practicing primarily at CAMC General, which is our Level 1 trauma center here in Charleston. I'm West Virginia born and raised, grew up in Wayne County, did my undergrad and medical school at Marshall, including surgery residency, did my surgical critical care and trauma fellowship at Indiana University, and have been back in West Virginia since then. And just, happy to be back home in West Virginia and enjoying taking care of friends, family, and folks that even I don't know. So
yeah, now we, as I mentioned, he's a Wayne pioneer. I'm an East Bank pioneer, so we've got a little bit, at least the nickname in common. But we were talking off the air because you're starting to get into the warm summer months here, and CAMC is a Level 1 trauma center. And you said something that kind of caught my ear because you said we're entering to trauma season. Explain that. What's that mean?
Yes, sir. Well, traditionally, we see an increase in trauma as the weather breaks. We have warmer weather. Folks go outside. They do more activities, motorcycles, ATVs, those sorts of things. I'm not saying that we don't have trauma in the winter, because we certainly do, but we do see more patients in the summer months and warmer weather. And so we always try to caution people, when the season comes on. Clearly, we're always prepared and ready, but we have enough job security. We want people to be safe if possible, and use helmets, use good common sense, those sorts of things, because trauma prevention is as much a part of our trauma center as is trauma care. Mm-hmm. And so we try to work in that regard as well. Is it
because, so it's a lot of it is because people are outside more, it's warmer weather, it's daylight longer, so more opportunity for trauma type things to happen if you're not careful?
Yes, sir. And with the weather, and we have our state's known for hardworking people. We have a lot of industry, a lot of hands-on work, which always carries some risk with it. And our people do. They push everything as hard as they can, trying to get the best results. And unfortunately, sometimes they do get injured during this process. And so we always want to be cognizant of that and try to, help remind people, because sometimes we take things for granted, and safety is certainly a factor. But that's part of the reason why we see the increase. And then we have a beautiful state. There's a lot of outdoor activities. We have the Hatfield-McCoy Trail, of course. We have hiking, all these different activities. And, again, safety and common sense come in and play a large role. But those can all potentially lead to trauma situations, unfortunately.
Dr. Seth Adkins is with us of WVU Physicians Group of Charleston. And you mentioned CAMC is a Level 1 trauma center, CAMC General here. What's that? There are designations. What does that mean?
Yes, sir. Well, the American College of Surgeons has a national level and criteria for trauma centers. The highest level that you can have is a Level 1 trauma center. And those requirements that we have to meet, we have staff available 24/7. Usually we have at least one or two physicians, trauma surgeons in the hospital at any time, in addition to our residents and advanced practice providers and a surgical ICU, and then ancillary support with other medical specialties, ortho trauma, neurotrauma, all of those folks. The designations do go into lower levels, 2, 3, and 4. Those centers would not necessarily have as many resources and sometimes would have to transfer patients to the level 1 trauma center in order to provide the patient with the best care.
Is that something that that organization looks at every so often? You have to be recertified for that?
Yes, sir. We do undergo recertification every 3 years, and they send in site reviewers, typically 2 physicians that will come in. They'll review cases, they'll review outcomes, they'll review our goals, our practice protocols, those sorts of things, and they go over everything. They spend a couple of days doing this process, and so it's a great honor for us to have that level 1 status and to maintain that.
Okay, I don't want to get ahead of myself here a little bit, or don't want to get ahead of myself. What determines if something is trauma? What is traumatic? So
typically we use a criteria, and again, this is created through protocols from the American College of Surgeons, but a lot of times mechanism. And trauma does entail certain mechanisms that sometimes we don't think about as trauma, such as burns, frostbite, those sorts of things, which frostbite not right now in this season. But any kind of traumatic injury, fall, MVC, motor vehicle crashes, ATV crashes, gunshot wounds, stabbings, those sorts of things.
Mm-hmm. Okay. So it would be, would be too general, would I generalize too much to say the more serious injuries, or?
Well, sometimes the injuries can be very serious.
Yeah.
And sometimes we take, the patient fell 3 feet. Well, they fell 3 feet. That's not a terrible distance, but at the same time, if they're on a blood thinner, they could have a pretty significant brain injury because of that. And so we take everyone seriously. We do have levels of activation for our traumas, priority 1 being those that are most critically ill, priority 2, less critically ill, but still someone that's been injured with a significant mechanism that we know could lead to serious injury or possibly even death without appropriate intervention. And being a level 1 trauma center, also would imagine you get transfers, right? That patients who are initially treated at maybe another facility will get transferred to CMC. Yes, sir. We do take transfers very routinely. Again, our beautiful state does have some rural areas, and thankfully there are some access hospitals that patients can go to. They get stabilization there. They may not have the resources to take care of them further, and so we work with those facilities and transfer the patients to our facility and go ahead and continue their care there and complete their care. Mm-hmm. And a lot of times those patients will come in, they come in different ways, but they'll come in through helicopter, right, a lot of times from through HealthNet. Yes, sir. We have a couple of different helicopter ambulance services that we utilize here, and they all do a great job. We work with them hand in hand to take care of the patients. There are standards that we have to meet, and we try to exceed those, and those companies do help us do that, and it's a major asset for our patients. The helicopter can travel much faster and in a straight line. There are no curvy roads, no potholes, which we know we don't have in West Virginia, of course, but it works very well for us. Dr. Seth Adkins with the WVU Physicians Group of Charleston. Give us a call, 304-345-5858, 304-345-5858. So let's go down this line a little bit. So a trauma patient comes in, and so I'm assuming into the emergency room or what the intake is, and then there's a determination, there's discussion, determination, okay, what's the next step? Yes, sir. So typically the patients will arrive in our emergency department. If we've been notified ahead of time, there will be a trauma team standing by waiting for that patient when they roll in the room. And we will quickly evaluate the patient. We'll discuss with the providers that are bringing the patient in, whether it be the ambulance crew or the air crew. They'll give us any report that they can. Then we do a very focused examination on the patient, determine if that patient needs emergency surgery versus some x-rays, CT scans. Of course, we'd check labs and provide a total workup to evaluate for any and all injuries. Unfortunately, trauma lends itself to situations where, patient may have a broken bone. It's clearly broken. They're complaining a lot of pain, but they could have another injury that would be easy to miss or overlook. And so we try to be very thorough and not miss those injuries. Mm-hmm. And you mentioned there's a team, so folks get called in or could get called in, right? I mean, you're kind of on call. Well, we are on call, but we're already there. That's the beauty of being a level 1 center. We're in the hospital. And so it's not a matter of, I'm stuck in traffic, I can't be there, thankfully. I'm already there. We have resident physicians that we work with, that we train, and they help us to assist in the care of the patients. We have nurse practitioners on our trauma team as well. Our ER physicians and their residents work together, and then, of course, our trauma nurses and our ancillary staff in that regard.
Okay, we're going to go to the phones here, and Bo is from Charleston with the call. Okay, go ahead, Bo, you're on the air.
Yes, I heard you gentlemen talking about medical helicopters, and I just had a quick precautionary tale for your listeners. My wife was involved in a bad accident about a year ago, and the medical professionals on the scene decided she needed a medical helicopter, and obviously nobody knew who was in network or out of network. And if they're out of network, you can get stuck with $40,000, $50,000, $60,000 in medical bills, sometimes more. And I don't know that, it's not fair to the patient lying there in a traumatic state if they're even capable of asking, who are you going to fly me out of here with? And it's just something that everybody needs to be aware of.
Yes, sir.
And some policies don't even cover it to begin with.
Yes, sir. I'm very sorry to hear that. I hope your wife made a complete recovery, and that is one of the downfalls of these situations. The billing and insurance can be difficult, unfortunately.
Yeah.
So I'm very sorry to hear that, but hopefully she had a good outcome and is doing well.
In her case, she did, yes. Thank you very much.
Thanks a lot, Bo. Thanks for the call. Yes,
Thank
it's
you,
8:32 on 580 WCHS, the voice of Charleston. But, he brings up a good point, Dr. Adkins, is these are decisions, these are life and death decisions that have to be made very quickly.
Yes, sir. And, our first responders do an amazing job. They have a very difficult job. They're out into the scene. Their resources are extremely limited. They do an assessment of the patient, take all injuries into consideration, take their location, and proximity to the trauma center. And so they make a decision. They do the very best they can, and they do a great job. And, we're very thankful that they do that for us. Unfortunately, we do hear stories like that from time to time, and thankfully she had a very good outcome, it sounds like. So she's doing well.
Mm-hmm. With the trauma center, you said sometimes you're notified. Talk about that a little bit, because I guess on transport you would be notified, but sometimes there isn't as much notification. I guess it depends case by case.
Yes, sir. Well, we utilize a transfer center, and we also have our MedCom, or medical communications team, and so they coordinate when an outside hospital says that we have a patient that needs to be transferred. They kind of coordinate that. They follow that patient en route via radio, phone, and kind of give us an estimate as to when the patient will arrive, and that way our team can be there ready to take care of the patient. They also give us some important information and details ahead of time so that we can kind of prepare. And, it sounds like this patient has a broken leg. We can go ahead and have our orthopedic folks notified. We'll be ready to get our x-rays and do the appropriate care to take care of each injury. But naturally, we still want to make sure that there aren't other injuries that we haven't recognized yet.
Mm-hmm. Communication, very key.
Communication is crucial, yes.
Yeah. All right, let's go back to the phone lines. Mark from Charleston, you're on the air with Dr. Seth Adkins. Go ahead, Mark.
Yes, in regards to the previous caller that was talking about a trauma experience that he had his wife flown and possible being out-of-network extra charges, is the situation on that is actually in the coding of how the charges were applied. If it's not coded as an emergency or a trauma, then yes, it can be counted as out-of-network. However, any policy that has a network and a non-network, say, for example, PPO plan, any time that a patient goes under a trauma situation, it's always going to be counted, if it's coded properly, as in-network, even if they take them to an out-of-network provider. So you have to be careful, and if a person does get charged for out-of-network services on a trauma situation, then they need to contact the claims department and have it recoded as an emergency situation, and then it would be paid as in-network. So maybe that might clarify some things for a few of your listeners.
Okay, Mark, we appreciate it. Thank you.
Mm-hmm.
All right. 8:35. This is 580 WCHS, the voice of Charleston. We're with Dr. Seth Adkins of the WVU Physicians Group of Charleston. And we're going to take our one and only break. 304-345-5858. 304-345-5858. Back in a moment on 580 WCHS.
Summertime is savings time at Walker Chevrolet in Nitro. Gene and Ryan have brought out all the best deals and tied them with a ribbon. Plan for your summer vacation and cruise in style with over $7,000 off MSRP on a Chevy Malibu LT. And if you're looking for a truck, this summer is the best time to save on the new High Country Silverado, now $13,000 off MSRP. You know Gene. For many years, he's been the dealer that makes friends every day by giving amazing deals and top-flight service. Now at Walker Chevrolet in the shadow of the Nitro Bridge, you can get the price you want on Malibu, Silverado, and all the rest of the Chevy line. Then, of course, there's Walker's pre-owned lot, packed with fine transportation at great prices. It just makes sense to call on Gene and Ryan to find the right vehicle at the right price. Summertime is savings time, and Walker Chevrolet is the place to go. Do yourself a favor and stop into the dealership that's making new friends every day, one deal at a time.
Good morning. There's an accident on I-64 eastbound, mile marker 56 at Montrose Drive. Also, watch for congestion on I-64 eastbound coming into Charleston. Speeding through the I-77 construction work zone between the 64-77 and 77-79 splits has become a major issue. The speed limit in the work zone is 50. Traffic brought to you by City National Bank, where you can get a home equity line of credit with rates starting below prime. Equal housing lender. For a convenient location near you, log on to bankatcity.com. I'm Jeannie Kay from the WCHS Radio Network Traffic Studio.
It's 8:37 on 580 WCHS, the voice of Charleston, and good Wednesday morning to you. Jeff Jenkins in this morning with Ask the Expert, and our expert is Dr. Seth Adkins of WVU Physicians Group of Charleston, and we're talking about trauma. We're going to talk about robotics in just a second, but Dr. Adkins let us know a little bit about himself earlier. He's from Wayne County and grew up here in West Virginia. Did you know, like early on, I want to be a doctor? Or is that a decision that came later?
It was something that I'd always wanted to do. My father had some health issues when I was a very young child. Had a rather complex surgery, and I grew up when I would see him without a shirt on, which was rare, but I did. He had a big scar on his chest and belly, and I would ask about that, and he told me I had to have surgery that helped save my life, and so that was important to me because I had my father growing up, and it was because of that surgery, thankfully. So. I wanted to hopefully help somebody else in the future that way. So that kind of led me into the healthcare and into medicine. Mm-hmm.
And you do surgeries, obviously, too. And so one of the things you use, and we're talking about robotics. And you say that word, and first of all, explain that. I mean, how surgery is done using robotics.
So robotics it's a tool and a technique that we use, and there is a misconception sometimes that people think that, they're just going to plug this robot up and it's going to do the procedure on me, and that's not the case. It is certainly a tool that we use, much like a hammer has a handle. Well, the robot has controls that we operate and control, but it gives us some extra mobility and flexibility. And it's a minimally invasive technique, meaning that there is typically not a large incision. There would be 3 or 4 smaller incisions, possibly 5 smaller incisions. But that would, hopefully lead to less pain, quicker recovery, less risk of hernias down the road, those sorts of things. And so that's where the robotics platform has really grown and shown some potential benefit for our patients. It is a newer technology. It's been around for probably 15 to 20 years or so. And the scope of the robotics practice has increased over those years. We've learned that we can do more things with it than what we did initially, and get the benefit of the platform and the system for those procedures. Mm-hmm.
So you make a small incision, and then the tool enters, and then what it shows you. I mean, there's a camera, right, and it shows you what you're looking for.
Yes, sir. So we would make. Typically a minimum of 3 small incisions, each one less than an inch. And through those little incisions, then we would put some carbon dioxide gas in the abdomen, which would inflate it like a balloon. And then we would place small tubes in through the abdominal wall through those incisions. Through those tubes, they have a seal, and then we would put our camera in. The camera allows us to look around 360 degrees, and it's a very specialized camera. We have had laparoscopic for 30, 35 years now, and that was a minimally invasive technique that was very, very common and popular, and robotics is more of an extension of that technique, using a camera and very small incisions to do larger operations underneath the abdominal wall and avoid a big incision. But once we do that, the robot is actually on a platform that we wheel up to the patient's operating table, and we call it docking, and so it attaches to those tubes, so it stabilizes. There's no potential movements and those sorts of things, and the surgeon then takes control of the robot. The tools are interchangeable. We have a surgical tech that assists us in these procedures, and if we would need a scissor or suction, they would attach that, and then we would have total control. And the robot is a very, very unique platform. It has a clutch that we can use to adjust control from one arm to another, and surgeons suddenly have 4 arms as opposed to 2, which is pretty handy. And if anyone's ever had someone hold a flashlight for them while they're working, we'll move it this way or pull this way. In this case, I've got 4 arms, so I'm doing it all myself. I don't have to convey that, and it allows us a lot more mobility and flexibility and more control, if you will.
How has it improved? It's 15 years, I would imagine. Technology is always improving. What's been, you think, the most significant improvements in recent years?
So the initial system was a little bit challenging to get it initial set up and the docking, and that process could take up to 15, 20, 30 minutes even sometimes in some cases. The newer system now allows us to dock in less than 2 minutes and gives us a lot more flexibility and mobility. Used to, it was more of a targeted, you had to pick one area of the abdomen that you would be working in. And so if you were going to work low in the pelvis, then you had to position accordingly, and you were pretty well constrained to working in that area. Now we have the ability, it's so flexible that it could, you put your trocars in, you work in the lower abdomen, you need to do some additional work in the upper abdomen, it rotates and you keep on going without any additional incisions, and a very, very quick transition, which is nice.
How do you train for that? If I don't even know if you get that in med school, or do you get that in your residence? I mean, how do you train to do that?
So it depends on the program where you train at, and I was fortunate enough I did have exposure during my residency training. But after that, even you still have to go through the certification with the robotics company, because they take great pride in their product, and they certainly don't want to turn in someone loose without proper training and without a certain amount of skill, because they want good results with the robot. They're clearly following this information very closely. So you start out by doing some cases in training. Then you go and observe certain proctors, and they're throughout the country. I mean, I went to Lexington, Kentucky to observe robotic surgeries, and then I did some more practice and did training on the robot itself. It has some training modules and programs. And then I went and did a training course in Atlanta, Georgia, where they have a medical institute, essentially, and you get to practice and do different techniques, and they show you the ins and outs of the robotic system. And then after you complete that, you would initiate your practice and work with a proctor for the first few cases to make sure that you're comfortable and you understand all of the concepts and that you're able to do a good job with the robot. Dr.
Seth Adkins is with us with WVU Physicians Group of Charleston here on Ask the Expert today. Number to call 304-345-5858, 304-345-5858. We're talking about robotic surgery. And I was reading up on some of this last night preparing for the show today. What are some of the common procedures that you use this with? Is there certain type of procedures more than others?
Yes, sir. The practice, people are constantly pushing the envelope or doing more with the robot, but very commonly we do a lot of hernia repairs with the robot. We do colon resections and bowel resections. Our urology colleagues use it for prostate surgeries and kidney surgeries sometimes. Our OBGYN colleagues use it for OBGYN procedures, of course. We also do some bariatric surgeries with the robot, and we also do anti-reflux. So folks that have gastroesophageal reflux disease and have to take Nexium, those sorts of things, we actually do surgeries to remedy that with robotics sometimes.
We were talking before we went on the air about the improvement of the camera. I mean, what you see. Talk about that.
So with the robotic system, it's a 3D camera, and the traditional laparoscope that we would use in minimally invasive surgery prior was a simple camera that produced an image that was on a monitor at the table, and so you would watch that. With the robotic platform, we actually have a large console similar to probably a 1980s model arcade game, but you lean into this and you're completely enveloped. You have a microphone, speaker, so you can communicate with the team at the table. With 2 controls for joysticks, and then pedals for your feet, because you have multiple features that you can use. We use that to initiate the operation. The visualization with the camera, though, is amazing. It creates a 3D image, and because you do lose a little bit of the tactile sensation, you make up for that by recognizing stretch on tissue by visualization, because your visualization is that much better. So you can't feel the tension, but you can actually see the tension.
And you mentioned that it's minimally invasive, and the recovery time is quicker. And I was just thinking, the really thankful for good health. And I remember I was young. I was like 6 years old, and had appendix surgery. Had an emergency appendectomy, and I was in the hospital for 11 days over here at the old General, the CMC, where you work, and that was a long time ago. But now, you can have surgeries like that, and it depends on case by case, I guess. But that's one of the things, right? Quicker recovery time because of the small incisions.
Yes, sir. Not every case, unfortunately, is good for the robot. Right. It is patient sensitive, and we look at each patient and each situation to make sure that we're using the very best approach for that case. But with the smaller incisions, and it does usually reduce the amount of pain postoperatively, reduces the amount of pain pills that we need to prescribe and to use to control the pain, and the risk of hernias, because anytime we violate, make an incision, and go into the belly and we repair it, that tissue is still not going to be as strong as it was to begin with, so that puts it at an increased risk for what we call an incisional hernia. And so with a larger incision, you have more risk of hernia formation. The smaller incisions tend to be less risk long-term for hernias to develop, and also the less risk for infection, because the smaller space operated with a cannula in it, or a trocar, that kind of protects that space from any kind of bacteria that could be involved. Unfortunately, these cases, sometimes in the abdomen, you'll have an abscess present, and so there's bacteria growing, and we use antibiotics and do all that we can to prevent that and prevent the risk of other infections. And that kind of helps us to do that as well.
What about the surgery time itself? Again, it depends on case by case, but is it generally shorter by using that?
It varies. Naturally, when you start out in a new procedure, new techniques, your learning curve is there, and it will take longer for the first few. And that's been one of the complaints for some senior surgeons and newer surgeons even, that I've got this operation, I can do it in 20 minutes normally. Well, if I do it robotically, it's going to take me an hour. Well, the first few might take you an hour, and then you'll see an improvement, and it's a gradual stepwise. But usually we're seeing, I think, in the research now, it shows that the time is about the same as it would take for traditional laparoscopic versus robotics now. And one of the other factors is the surgeon does not have the fatigue as much by standing, lifting, pulling, holding, and twisting during the surgery. We're allowing the robot to do some of the work for us. And so, we can go out and dig a ditch with a shovel, or we can go out and dig a ditch with a small excavator and be able to done a lot faster and not very tired. So that allows us to do a little bit more and stay sharper, I think.
Let's go back to the phones. Mark on a cell phone. It's 8:49, and Dr. Seth Adkins is with us of WVU Physicians Group of Charleston. And Mark, you're on the call. Go ahead. Go ahead, Mark. I hear him there. Yeah, go ahead.
This is Wayne. I'm sorry.
Wayne, I'm sorry, Wayne. Go ahead.
It's no problem. Hey, first of all, I'm impressed with Dr. Adkins' knowledge, and not just his medical surgical talents, but his knowledge and able to get information out to the public. Hey, my question is, what's the biggest challenge to maintaining these services? Things like retaining of staff, getting enough clinicians, or is it the financial side where uncompensated care is eventually going to outweigh being able to do the service?
Thank you, Wayne.
That is a very, very tough question. And unfortunately, I don't think there's a real simple, easy answer. I think it's certainly a combination of factors. Healthcare costs are always a hot topic. We do the best that we can. And, for myself and my colleagues, the cost, and, the gentleman spoke earlier about the cost of the air medical transport. I certainly knew that it was expensive. I didn't know exact numbers. And, again, I would always want to keep that as low as possible. In terms of trying to retain staff, it's all about taking care of our team. We try to recognize everyone on our team. It's not just a single person approach. One person can't do this by themselves. It takes good support staff. Communication is always a very, very important factor. It's important, and the hospital has to have a certain amount of buy-in, literally and figuratively. The robotics platforms are costly, over $1 million, but they are relatively durable, and so there are some studies now that have shown that the cost effectiveness is there. You will look at it in a different way. You can do the surgery open, and the patient would stay in the hospital for 5 days. But we all know what the hospital is going to charge for a day in the hospital. We can do it robotically. The patient stays in the hospital for 2 days. The actual operation costs a little bit more, but it's going to be less overall than the extended stay, and hopefully with a quicker recovery and the same or better outcome.
Mm-hmm. And you give, as you consult with your patient, what have you found their learning curve to be in understanding robotic surgery?
Patients are amazing today. Everyone knows the internet, and if they're not comfortable using the internet themselves, just like yourself last night, researching robotic surgery, there's a ton of information out there. The company, of course, provides information. Different centers provide information, and it's very important that our patients know and understand. And I always try to convey, this is what we have going on. This is what I want to fix for you. This is how, because if they don't understand it and don't have a buy-in, then that creates a problem. That's going to make it harder for the recovery. That's going to make it harder for the procedure. So communication is very, very important. And the ability to research these things out on their own. Patients come in, they're always very prepared, and that makes my life easier. There's clearly different techniques that different places and people use, and there's advantages and disadvantages to each. And so I always try to clarify that with them. But it's always good and entertaining and interesting too. Some people, the concept of robotics is completely different, but for most people, they're starting to see and understand. And everyone now tends to know someone that has had robotic surgery or knew somebody that had, And so it's very interesting for me now to see patients, and you say, well, the patient's mom is with them. Well, I had this surgery 30 years ago, and I've got this big scar, and now you're going to do the same surgery, and they're going to have 3 little small scars. Well, yes, that's the way it is this time. Hopefully, now there's always the potential that we would have to convert to open, but it's pretty unlikely. So it's always impressive for me. I'm a bit of a history buff, and to see how it's changed in medicine. And, even in my time in practice, I'm not that old, but I've noticed and seen changes already in a short amount of time.
Mm-hmm. So you don't mind, Doctor, people looking up things on the internet and getting some information, because I would guess, that allows them to engage with you, and you can
It does. It helps to create a conversation, gives us some baseline information. Now, naturally the internet's full of good information, and there's some bad information as well. And expectations can be inflated or deflated in some cases. So, I try to give them evidence and use evidence-based medicine and explain, well, there's some truth in this, there's a lot of truth in that, there's no truth in what you've read, and so that they do have a good understanding. And then hopefully they go back behind me and they'll fact check. That's how to be completely involved in their own care.
Right, exactly. And Dr. Seth Stevens is with the WVU Physicians Group of Charleston, and they're at CMC General. And you can find out more at WVUPC.org. That's WVUPC.org. The phone number there is 304-388-7270, 304-388-7270. So you mentioned that these type of operations are growing. And I'm just going to throw something out here. How many do you think will be done today, in any one day at CMC?
Oh, well, from my understanding, because our robotics program is based at Memorial.
Right.
But usually, my understanding is somewhere between 4 and 8 cases a day, typically robotically, between the two machines, and that number is going to continue to grow, I think, as people become more aware and recognizing the benefits and the potential for better outcomes with the robotics program.
Right.
And so I think that it will continue to grow, and I think that we'll probably see the hospital in the future and see this and the benefit and the patient outcomes, and they'll probably invest and make the program even larger.
And our future doctors in training now getting more opportunity in school?
Yes, sir, they are. And because they recognize the importance of the robotics program, they see the data. And the robotics programs are very unique. The platform itself does have what we call a teaching console. So if you remember the old driver's ed car in high school that had 2 steering wheels, well, that's essentially our teaching consoles. And so they get to see, they can have some control. They can get 1 arm, they can get 2 arms, they can get no arms, but they still get the experience. And as they establish their comfort level and their understanding of the machine, then they get to progress through the training and do more with it under supervision.
All right. We have a couple minutes left here with Dr. Seth Adkins. So, again, back to some personal questions here. All right. Do you remember your first surgery?
Oh, yes. Yeah.
What was it?
Very simple, incision and drainage of an abscess.
All right. Well, yeah, is that okay? I mean, is that for the first one?
That's what the patient needed.
That's very good. I guess everything was okay, right?
Yes, sir.
So, how many surgeries have you done?
I have not looked at my logs in a while, but done several.
Yeah, over the years.
Yes,
several over the years. And so, as you said earlier why you got into it. I mean, what has surprised you? Was it anything you expected when you were growing up?
Coming from a family with no physicians in the family. I mean, my dad was a carpenter and then ultimately worked at the post office, and my mom was a teacher. We didn't have anyone in the family in healthcare. It was going to be a surprise regardless. The amount of paperwork, even in our paperless electronic era, there's still considerable amount of paperwork, but you take the good with the bad. I love to do surgery. I love to interact with patients and people. I'm not as much of a fan of paperwork, but it has to be done. So I think that we will see some changes in that in the future as we determine how to proceed with our healthcare in the United States. But I'm very happy and blessed to do what I do.
Are we producing enough doctors now, or where are we?
So that is a great question. And so right now it seems like there are some areas that are definitely some specialties that we are shorthanded on. And so the American College of Graduate Medical Education, the organization that kind of oversees medical education, they're working on improving the number, adding to the programs, or increasing the size of the programs because our population, of course, is growing. We definitely want to be able to take care of everyone and take care of everyone in a timely fashion.
Mm-hmm. And in West Virginia, we're an older population, right? So that lends itself to more health care.
It does, but it lends itself to typically a specific kind of problem set typically. And with certain populations, you can expect certain disease processes and so forth. And so naturally we gear ourselves to be prepared for those more, still able to do anything else that we need to. But yes, definitely it does create an increase in need for our system. And being a rural state, we have 3 medical schools in the state that do a great job providing trainees and future doctors, and then the trick is to get them to stay here in West Virginia as well.
All right, that was a quick 40 minutes, a very quick 40 minutes. I knew when I heard you're from Wayne, I had no problem. I knew he's going to be a good conversationalist. So thank you, Dr. Adkins. We appreciate it. Thanks for the time.
Thank you, sir.
Yeah, Dr. Seth Adkins, WVU Physicians of Charleston's been with us. Again, their website, WVUPC.org. WVUPC.org. Great having them on Ask the Expert today. Their number, 304-388-7270, 304-388-7270. Stay tuned. ABC News is on the way next. This is 580 WCHS, the voice of Charleston.
.580 WCHS AM, 96.5 FM Charleston, and 104.5 FM Cross Lanes, a West Virginia Radio Corporation station. It's 9 o'clock.
From ABC News, I'm Sherry Preston. The House Oversight Committee is set to vote today on possibly holding Attorney General William Barr and Commerce Secretary Wilbur Ross in contempt. It's over in contempt. It's over in contempt. It's over in contempt.